Hi, I'm Kate Heil. I'm the Full Circle Health NAMPA Primary Care Psychiatry Fellow. So I did my family medicine residency out in Nampa, and then I did addiction medicine fellowship in Boise, and I work in both places now. So that's me. Thanks, guys, for coming today. I'm going to talk a little bit about the treatment of alcohol use disorder in pregnancy and beyond. Um, I know that I have a soft voice, so please let me know if you can't hear me. Okay. Okay. First off, I have no disclosures. So learning objectives for today are to learn a little bit about the physiology of alcohol and pregnancy and the risks therein, understanding prevention and treatment options during pregnancy, and then breastfeeding physiology as it relates to alcohol and kind of treatment options there. All right, so first off, starting off with some kind of person first language or stigma-free language. Words that we try to avoid are things like addict or alcoholic, and rather say things that emphasize the personhood and humanity of a person who's struggling with a substance use disorder or alcohol use disorder, and then not using words like clean or dirty, but rather being more specific with what we mean with that, like actively using or not, or like urine drug screens. Be specific when you're talking with that, like testing positive for a substance or not. Right. And another brief review here. We view the here we kind of go by the medical definition, or sorry, the medical or ACM view of addiction, which is viewing it as a treatable chronic medical disease involving complex interactions between a person's neurobiology, their genetics, their environment, and then their individual life experiences. Okay, so let's get started with regards specifically to alcohol use in pregnancy. So I wanted to start out with a brief discussion on epidemiology. And this is from the National Survey on Drug Use and Health. The most recent data are actually from a couple years ago. So just keep that in mind. But in general, the most common substances that women use during pregnancy are alcohol, tobacco, marijuana, and opioids. In general, the prevalence or the amount of use is much less during pregnancy when compared to when women are not pregnant. But still, about 9 to 11% of women had used alcohol while pregnant, and then between 4 to 5% would meet criteria for alcohol, or sorry, binge alcohol use, and then about 1 to 2% would meet criteria for heavy alcohol use during pregnancy. Okay, so going into that definition a little bit further, the definition for binge alcohol use would be consuming 5 or more drinks on one occasion, which would be about 2 hours for men or 4 or more for women. So this type of alcohol use, specifically for women and pregnant folks, can be associated with adverse pregnancy outcomes, including fetal alcohol spectrum disorders, and then other kind of like violence against women, other violences, accidents, intimate partner violence, and things like that. This is important to think about for our population because binge alcohol use is most common in those who are between the ages of 18 and 34. So those are like the prime kind of childbearing years. And I'll go over a little bit more about the physiology with the specific risks associated with binge drinking and higher risk of fetal alcohol spectrum. So heavy alcohol use, next thing, 8 or more drinks per week for women or 15 for men. And then there's another definition, just to make things a little bit more confusing, but excessive alcohol use. So excessive alcohol use, these particular things would fall under that category, and those would be binge drinking, heavy drinking, or any alcohol used by a pregnant woman, or in the United States, anyone under the age of 21. Because of course it would not be legal under the age of 21. So any alcohol used by a pregnant woman is considered excessive. by this CDC definition. Yeah. Mhm. Okay. Sorry, my screen froze for a second. Um, Okay, so when we think about alcohol use in pregnancy, there's a lot of, opinions. There's a ton of stigma, and part of that is because we all know that alcohol is a teratogen for the fetus, for the baby. The substances with the most potential for teratogenicity would be alcohol and tobacco, and of course, those are very common substances that people use. So just a brief definition on teratogen. That is a substance that may produce an alteration in the offspring's physical structures and or behavior when used during gestation. Important thing to think about is teratogenicity is kind of hard to suss out because there's often a lot of confounding factors, including nutrition, stress, other use of medications, things like that, maternal physiology, and fetal physiology. But we do know that the things that have the most potential for teratogenicity are alcohol and tobacco. Okay. So I'm a family doctor, and thinking about that, we think a lot about prevention. And when we think about alcohol use in pregnancy, really focusing on prevention. So this is where the saying an ounce of prevention is worth a pound of cure really kind of comes into play. So both the AFP, which is the American Association of Family Physicians, and ACOG, which is American College of Obstetrics and Gynecologists, along with the American Society for Reproductive Medicine, agree on screening women for unhealthy alcohol consumption, and counseling on on the risks of fetal alcohol spectrum disorders, other harms from alcohol use during pregnancy, and then counseling and education on the risks of substance use during pregnancy. So that would include alcohol, tobacco, and other drugs. ACOG specifically in their guidelines and kind of opinion statements note that in their opinion, there's no safe level or type of alcohol use during pregnancy. And again, we do know there's some increased risks of certain things with specifically binge drinking. So the goal of these, societies kind of coming together, making their guidelines, making their opinions, is to reduce the risk of adverse health effects for the pregnant person, the fetus, and then the baby, through optimizing health, addressing any modifiable risk factors, and then, of course, providing education to our patients regarding what a healthy pregnancy can look like and how to obtain that. Briefly about fetal alcohol spectrum disorders, or FASD. Unfortunately, this is the most common known non-inherited cause of developmental disability in the United States. And we know that we can help prevent this by screening and then providing education and treatment for alcohol use disorder. So the thing that we do know is fetal exposure to alcohol and sustained exposure to alcohol or intake during any trimester of pregnancy is associated with an increased risk of fetal alcohol syndrome. So fetal alcohol syndrome would be the more severe kind of end of the fetal alcohol spectrum disorders spectrum. And we know that like the certain effects or certain issues that will be kind of prevalent or evident later on, I should say, do relate in some part to the age of gestation when the exposure occurred, but we do know that there can also be effects during any trimester. Okay. So going over the physiology a little bit, sorry to get a little bit granular here, but this helped me think about things when I think about kind of counseling patients, just having that kind of knowledge of why women and men may be a little bit different and why pregnancy physiology specifically is a little bit different when it relates to alcohol. So women can have can have higher blood alcohol levels, or BAL, and greater intoxication than men, even with the same amount of alcohol consumed. And there's a couple differences in physiology that can account for that. So one is a higher percentage of body fat, a less active form of liver alcohol dehydrogenase, or ADH, and then also specifically less stomach alcohol dehydrogenase. So what that means is there's less alcohol dehydrogenase, which is a enzyme that helps break down alcohol. So there's less of that in the stomach of females when compared to males. And that means that alcohol is not metabolized before it gets out of the stomach. So all of that kind of together means that there's less efficient metabolism of alcohol, oftentimes in women, which increases the blood alcohol level. Okay. So that's men versus males versus females. And then when we think about pregnancy physiology specifically, we know that blood alcohol level will be increased with women because relatively because of these physiologic differences. And then we need to think about how that would affect the baby. So alcohol can pass from the maternal blood through the placenta and then to the fetus. And then the fetus ends up getting exposed in a number of different ways, actually. And so that's important to think about. So I'll go over that. Alcohol in the fetus is broken down much more slowly. Oops, sorry. So the blood alcohol level remains higher and kind of sticks around longer. And when the baby, has metabolizes the alcohol through their body, they urinate it out, which goes into the amniotic fluid. And then the amniotic fluid also eliminates the alcohol slower than in the maternal circulation. And then that kind of exposes the baby to alcohol longer, kind of like a circular process. Those baby, if the alcohol is kind of accumulating in the amniotic fluid, the baby swallows it, which is part of normal physiology there, and then it excretes it again via the kidneys. So it's exposed. The baby is exposed in a lot of kind of different ways, and is exposed multiple times, if that makes sense. Okay. So now I want to kind of take a pause and provide a little framework from ASAM. So this is from our ASAM textbook, thinking about kind of, like I said earlier, there's lots of opinions. There's a lot of stigma surrounding women, or pregnant women, sorry, who consume alcohol or any kind of substance, which of course then can provide a barrier for women to seek care. They may not admit to use because they're afraid of the stigma that they might face from medical providers or other people, and or legal implications, custody implications as well. So when we are treating patients who are pregnant, who may be using substances, I think it's helpful to kind of go back to this framework, which is, I'll just quote it. Women who use substances during pregnancy often do so in the context of intricately complex individual, social, and environmental factors, which include poor nutrition, extreme stress, violence of multiple forms, poor housing conditions, exposure to environmental toxins and diseases, and depression, all of which can impact postnatal outcomes. And then if you remember, teratogenicity can be affected by a lot of confounding factors, some of which are included here as well, like poor nutrition, stress, environmental factors, things like that. If you work in primary care or obstetrics and gynecology, you are probably familiar with doing screenings. So these are some screens to look for substance use, alcohol use that are specifically validated for pregnancy. So there's the 4Ps, which is asking about parents, partner, past and present. There's the NIDA quick screen, and then there's a CRAFT, which is used for women 26 years old or younger. And then we use that in adolescents to screen for substance use too. Okay. And then going over kind of pregnancy specific risks, these are the main ones. So there's withdrawal, a little bit of difference there, and then some, of course, risk for fetal alcohol spectrum disorders. Okay. So going through withdrawal first, the ASAM guidelines do recommend that inpatient management be considered for all pregnant patients going through alcohol withdrawal, due to both the risk for the mom, risk for the baby, and then, of course, risks of complicated alcohol withdrawal that apply to anybody. They do also offer or recommend offering inpatient treatment, especially for CWA scores greater than or equal to 10. So that's a little bit lower than what we think for folks who are maybe not pregnant. And then they also do recommend screening women of childbearing age if they do come in seeking help, like whether that be in the office or the ER or wherever, screening them for pregnancy if they're seeking help with alcohol withdrawal, because that's important to kind of be aware of. But they do not recommend delaying any kind of treatment for the woman going through alcohol withdrawal until the pregnancy test results. And, thankfully, our test results pretty quickly. So, and then they do also specifically call out that CWA scoring is appropriate to use for pregnant women. And they do recommend, not, they do recommend understanding that some potentially common symptoms of pregnancy, like nausea, headache, insomnia, and anxiety, may also be related to alcohol withdrawal. So specifically, not underscoring people because you assume that those things are from pregnancy. And then, of course, definitely consult with an OB-GYN or maternal fetal medicine, MFM, if a pregnant woman is needing assistance with alcohol withdrawal. And then I should say also, if they meet any other kind of contraindications to ambulatory alcohol withdrawal management, like history of alcohol withdrawal seizures, unstable home life, all of that, of course, they would qualify for inpatient treatment. And as far as I am familiar with, I think in this area, the general kind of standard of care is to offer inpatient management, and preferably inpatient management for pregnant women going through alcohol withdrawal. Okay. Last little bit about treating withdrawal. So going through the ACAM guidelines, they do call out that the use of benzodiazepines and barbiturates are still the medications of choice, which is similar to what we use in folks who are not pregnant. Of course, we know that there is a small risk of teratogenicity with use of these medications during the first trimester, but we have to weigh that risk with the risk of fetal alcohol spectrum disorders and the risk of severe alcohol withdrawal. So keep that in mind. So we do want to treat the alcohol withdrawal, and we want to help the woman go through withdrawal safely and to get into recovery. They do also call out that one of the other medications that we do use sometimes, but not super often, is valproic acid, but that's not recommended to use due to higher teratogenic risks. And then if a woman is undergoing treatment for alcohol withdrawal close to delivery, whether that be preterm or at term, they do recommend using short-acting benzodiazepines to reduce neonatal risk of intoxication and withdrawal after delivery. And then, like with anything, when we're treating pregnant women, we base the fetal monitoring upon the stage of pregnancy. So whether that be fetal monitoring, outside, that type of thing. There are risks of abruption, preterm delivery, fetal stress, and intrauterine fetal demise with alcohol withdrawal during pregnancy. Okay, so just a brief refresher. Treatment for alcohol use disorder, like maintenance specifically, so after they go through withdrawal. For non-pregnant folks, there's FDA-approved medications for alcohol use disorder. That'd be naltrexone, disulfiram, and acamprosate. And then off-label medications would be gabapentin, baclofen, topiramate, sometimes Zopran is kind of under investigation, but just that refresher there. And then thinking about treatment while pregnant, we don't recommend using disulfiram. That's actually kind of contraindicated because of the potential for acetaldehyde accumulation and fetal abnormalities as well. So don't recommend, or the guidelines don't recommend using disulfiram during pregnancy. Naltrexone is a little bit more nuanced, so I will go over that in the next couple of slides. Acamprosate, I couldn't find, or there isn't much literature specifically about acamprosate with humans. There are some adverse events observed in animal studies, but some like small case reports show potential benefits of use of acamprosate. Gabapentin is off-label use for alcohol use disorder. That is one where there is a little bit more information about use during pregnancy. So technically, gabapentin is like an anti-epileptic. So we recommend folic acid supplementation. What if this medication is going to be used? And the general recommendations are, having an informed consent discussion with the mom, as there are some potentials for cardiac malformations, preterm birth, risk of NICU admission, higher risk of neonatal withdrawal from gabapentin, and that's all for gestational age, and using the lowest dose that is still effective. So that's one that's kind of like consider with caution, but still has been used. Okay. So naltrexone has a little bit more information, or we're getting a little bit more information about naltrexone now. I found a recent case report that followed 7 pregnant individuals that were using naltrexone to help with their recovery, either oral or injectable naltrexone. And they studied these folks, and they were in recovery from opioid use disorder or alcohol use disorder. So I'm kind of going over the results of that study. They addressed a lot of things. There were some, case report, I should say. They addressed a lot of factors. So they included both folks who had opioid use disorder and other folks with alcohol use disorder. A lot of studies that you'll find are kind of comparing methadone, buprenorphine, and naltrexone. So a lot of the literature more focuses on opioid use disorder. But yeah, so going through that, they split up the folks. There was 4 folks with opioid use disorder and then 3 with alcohol use disorder. So one thing that was a little bit interesting is that 2 of the pregnancies of folks with alcohol use disorder were actually the same person, but she just had consecutive pregnancies. And in one pregnancy, she used oral naltrexone, and then in another pregnancy, she used injectable naltrexone, extended release naltrexone. So overall, this was a prospective cohort study, and they found some reassuring things kind of overall. So the mean gestational age at delivery was about 37 weeks, and they were all vaginal deliveries. There were no reported fetal anomalies. There was one preterm delivery, and there were some neonatal complications in NICU stays that related more specifically, they think, to the fact that the child was born preterm rather than exposure to naltrexone, they thought. So keep that in mind. There were no returns to use of opioids, but one individual, the individual who had the consecutive pregnancies, returned to use of alcohol briefly postpartum. And they had a high success rate with parents having custody of the children upon release from the hospital. And then a year later, the individual who had the consecutive pregnancies but returned to alcohol use very briefly had not retained custody for the full time there. So they came to the conclusion that naltrexone is a potential treatment option for pregnant women with alcohol use disorder. Okay. So when we think about, using naltrexone, if a person is stable on naltrexone, stopping medication does have risks, of course, as does starting a medication. So those would be like fetal distress, destabilization of recovery, and then increased risk for overdose. Yeah. And also in this study, breastfeeding was encouraged for these folks. Overall barriers to implementation of use of naltrexone or treatment of alcohol use disorder during pregnancy, regards to kind of lack of national guidelines regarding naltrexone in use in pregnant patients. And so there's a lot of, anxiety about using this medication if there's not like a formal guideline about it, leading to provider discomfort, and then of course, limited access to treatment. Okay, so the last little section here is with regards to breastfeeding and breastfeeding physiology with regards to alcohol. So the level of alcohol in breast milk is pretty similar to what's actually in the maternal bloodstream. So CDC recommends waiting about 2 hours after having alcohol before breastfeeding because the alcohol levels in breast milk are the highest about 30 to 60 minutes after drinking alcohol. So they recommend keeping it to one standard drink a day or less for for women who are breastfeeding. Um, that is their general recommendation, and then waiting for about 2 hours after having alcohol or before breastfeeding. And then they did note specifically that milk letdown will be reduced after 5 or more drinks. Okay. And then when we think about medication treatment for alcohol use disorder during breastfeeding, disulfiram, it's not known if this is is present in breast milk, but it's not recommended by the manufacturer. Naltrexone, the metabolites are present in breast milk, and so that's again kind of a risk-benefit conversation to have with the patient. And then acamprosate, again, unknown if the metabolites are present in breast milk. The manufacturer recommends caution. And then gabapentin, it is present in breast milk in one study. Adverse events were not reported. And so again, this is another risks-benefit conversation, and things specifically to monitor for in the infant would be drowsiness, making sure they're meeting milestones, and then gaining adequate weight. And that is it.
Thank you, Cate. That was a great presentation, and I appreciated you going through all of the different treatments. Want to open it up just for a few minutes for questions from our audience members. So if you have any questions or comments for Cate, feel free to unmute yourself or put that into the chat. And while we're kind of waiting for folks we might get this kicked off with some panelists. And so let's see, we've got Todd, Brenda, Eli, Kathy, and Jake. Todd, any thoughts, questions, comments for Cate? Oh, you're muted, Todd.
Oh, sorry. No, I was just saying, I thought it was an excellent presentation. I really don't have much to add. Thought she covered things really well.
Great, thank you. Eli, I'll go to you next.
All right, the mute. Yeah, I think I don't really have any comments or questions coming from my perspective.
Okay, Jake, Brenda, or Kathy, any comments or questions?
I'll jump in. First of all, I'm really excited that Cate is staying in the area. It's very exciting. Hope to get to continue to work with her. Cate, quick question on the, you mentioned in that study on the naltrexone that 2 of the subjects went back to drinking, and then 1 of the babies got admitted to the ICU for suspected FASD. I'm wondering if they just do that automatically, if there's any kind of exposure, or if the patient or if the baby actually was found to have fetal alcohol spectrum.
Sorry, I think that was unclear. The infant that was admitted to the NICU was admitted more related to their prematurity. And then there was an infant that was suspected to have fetal alcohol spectrum. They were not admitted to the NICU for that. And I should say also, I went more over kind of like medical things rather than kind of biopsychosocial. Of course, we want to recommend our pregnant patients, if they are interested in counseling, community supports, peer supports, all of that, obviously offering that to them, and then offering education specifically regarding like risks of fetal alcohol spectrum. And then if a child is diagnosed with fetal alcohol spectrum, there's getting them the earlier, the better, to get hooked up with resources to help with their meeting developmental milestones and things.